Historically designated as the forgotten valve, the tricuspid valve has undergone a major clinical paradigm shift. Driven by advances in multimodality imaging and transcatheter edge-to-edge repair, contemporary classification schemas have evolved beyond a simple binary view of tricuspid valve disease. Understanding its etiopathogenesis requires separating primary or organic disease from secondary functional phenotypes, the latter of which comprises the vast majority of clinical cases. Secondary TR accounts for over 90% of clinically significant cases in developed nations. In these phenotypes, the valve leaflets and chordae are anatomically normal. Regurgitation is entirely driven by altered right atrial or right ventricular geometry and shifting hemodynamic loading conditions. Contemporary guidelines and consensus classifications distinguish between two distinct functional phenotypes based on the primary anatomic driver of remodeling. Atrial secondary TR. Primary driver is right atrial enlargement and contractile dysfunction, typically precipitated by long-standing atrial fibrillation or heart failure with preserved ejection fraction. Pathomechanism. RA dilation leads to direct expansion and distortion of the tricuspid annulus. Because the leaflets fail to grow proportionately to match the expanding annular area, an imbalance between the leaflet tissue area and the annular orifice develops, resulting in malcoaptation. Geometric features. Minimal or absent leaflet tethering. RV geometry, volume and longitudinal function remain largely preserved in the early to mid stages of the disease. Ventricular secondary TR. Primary driver RV dilatation, spherical remodeling and systolic dysfunction. This is most commonly secondary to left-sided valvular heart disease like chronic mitral or aortic valve disease, left ventricular failure or precapillary pulmonary hypertension. Pathomechanism. As the RV remodels and dilates, the papillary muscles are displaced apically and laterally. This displacement exerts excessive tension on the chordae tendineae, causing severe systolic leaflet tethering